Why do we lampoon people who either receive mental health services or provide them? Why is that such a recurring trope in popular culture? I think we do so to protect ourselves from the threat, right? If we can trivialize it, if we can make fun of it, how much of a threat can it really be? So I've told you a little bit about the etymological origin of stigma as well as the kind of operational definition. And now we've got to go around the problem of trying to do something about it. And remember, stigma is the thoughts and attitudes. Discrimination is the behavior. So for some people, it's pussyfooting around the word to just talk about stigma and not talk about the resultant behavioral discrimination. Stigma starts really young. It starts in childhood. And we have very, very good experimental evidence from kids in grade 3 who have zero literacy in mental illness, that they already have profoundly pejorative attitudes towards people with mental illness. And this is something that's been very, very well demonstrated in the research literature, and I won't bore you with it here. But it manifests in daily life at the hospital where I work. I suspect also at the hospital where Mark works. CAMH, as you may know, is a big hospital. 535 beds. It's the largest mental health facility in the country. We have no gift shop. Why do we have no gift shop? We have no gift shop because we don't have the human traffic of visitors for the 535 inpatients and the many thousands more outpatients for that tangible demonstration of support. You could go to the smallest community hospital in Northern Ontario, and when you walk in, there will be, at minimum, a little stand with a lady with a blue smock on and beseeching you to load up before you go visit someone. Because gifts, flowers, get well cards, these are the tangible expressions of support, of community, and ultimately of hope. And they are distinctly absent from the mental health environment. And studies in hospitals like Mark's that have actually gone on the medical wards, the surgical wards, and the psychiatric wards of general hospitals and have done a simple count of the numbers of cards, gifts, and flowers, have shown that on the psych wards, they're less than half of what you would see in any other clinical environment. This again speaks to that horrible sense of isolation and distance that compounds the suffering of somebody who's experiencing a mental illness. And this is nothing new. Let me read to you a letter that a guy wrote in 1841. He was a lawyer, and he wrote this letter to his law partner. He said, "I'm now the most miserable man living. If what I feel were equally distributed to the whole human family, there would be not one cheerful face on earth. Whether I shall ever be better, I cannot tell. I awfully forebode I shall not. To remain as I am is impossible. I must die or be better, it seems to me." This letter was written by a young lawyer whose family was very worried about him as he struggled with a depression. They sent him to live with cousins and said, "For God's sake, keep him away from the river's edge, because we think he'll throw himself in." His depression lifted spontaneously after a number of months, and he resumed his law practice, and then he ran for public office and was elected president. It was Abraham Lincoln who wrote those words. Flash forward 100 years, and another politician in another country writes a letter to his friend and says, "You know, when I was young, for 2 or 3 years, the light faded out of the picture. I did my work, I sat in the House of Commons, but black depression settled on me. I don't like standing near the edge of a platform when an express train is passing through. I like to stand right back and, if possible, get a pillar between me and the train. I don't like to stand by the side of a ship and look down into the water. A second's action would end everything, a few drops of desperation. And yet, I don't want to go out of the world at all at such moments. Is much known about worry, Charles? His friend Charles was known to the rest of the world as Lord Moran, and the author of the letter was Winston Churchill. And it was written at the height of World War II. That was sort of the secret history of depression, among politicians in particular. When I was an undergraduate in the United States, Richard Nixon was president. Abraham Lincoln was no longer president when I was an undergraduate. And I worked vigorously on the campaign of George McGovern, who was a Democratic nominee running against Nixon in '72. I don't want to call myself a rainmaker or anything, but with my help, McGovern lost 49 out of 50 states, including his home state. But I helped him carry Massachusetts, and I feel kind of responsible for that. But his vice presidential running mate, a very skilled man, was Senator Thomas Eagleton. And he's now a largely forgotten figure. He was a great man. He's just died a couple of years ago. The media found out that Eagleton had been treated for depression in the 1950s. And he'd been treated successfully with electroconvulsive therapy, ECT, shock treatments. Got them all better. And within 48 hours, he was dropped from the Democratic ticket because it was a liability to have somebody who had had depression successfully treated. Now, I was 18 years old. I was stunned. And I've always argued ever since that the only politicians we should be concerned about are the ones who haven't been treated, not the ones who have been treated. But times have changed, and politicians are now being much more open about their experience, and it cuts across all party lines. And in my current position as chair of the Mental Health Commission, I've seen this because I've had to interact with all the political parties, and this is a nonpartisan issue. Bob Rae has talked extensively about his own struggle with depression. When Dave Batters, a former Conservative MP, killed himself, the eulogy was given by Stephen Harper, and it was a profound eulogy about the everyday reality of depression, what it is and what it is not. And of course, for Harper, the story is that his grandfather, who was a very popular high school principal in Moncton, drowned himself in the wake of a depressive episode. So what can we do about stigma? Well, there's basically three things we can do. One is to protest. And, the problem with the protests alone is that they can often trigger backlash. There's crazy people marching on Queen's Park again, something like that. Or education. Now, education always raises literacy, but it doesn't always change attitudes and behavior. And the third thing we can do is contact, human contact, which reduces stigma through a personal connection. And most of the research evidence suggests that our most potent intervention is human contact. It's a lot harder to pathologize the other once you've spoken to them. In World War I, when they would have armistices and brief truces on the fronts, and these guys who were mowing each other down from a distance of often 300 yards between the trenches, if they broke bread together on Christmas Day kind of thing, it was very hard to go back to shooting each other. So, at the Mental Health Commission of Canada, one of our principal initiatives is something called Opening Minds. Now, how many people here, and I won't be hurt if you don't put your hand up, how many people here are familiar with the Mental Health Commission of Canada? Okay, I'm devastated. The Mental Health Commission of Canada was set up in 2007 with a 10-year mandate to do a number of things to drive mental health reform in Canada, including developing, implementing, and evaluating Canada's first national anti-stigma, anti-discrimination campaign, the likes of which this country has never seen, but also developing a national mental health strategy for Canada, which we released in 2012, developing a knowledge exchange center, and then more recently conducting the at-home chez soi study. How many people are familiar with at home? Okay, well, this is something you can actually take some pride in as Canadians. That doesn't always happen. But At Home Chez Soi is the world's largest study of a treatment intervention for people with homelessness and mental illness. And it was conducted in 5 Canadian cities: Vancouver, Winnipeg, Toronto, Montreal, and Moncton. It involved 2,235 homeless, mentally ill Canadians who were randomly assigned to either treatment as usual, which is, of course, shelter, hospital, emergency room, and jail, versus a Housing First initiative, where people were often housed within 48 hours. It recently concluded. It's now being replicated in 3 cities in France, and it has stimulated interest in this model across Canada in terms of addressing homelessness. But I want to speak about Opening Minds, the anti-stigma initiative. This is an evidence-based initiative rather than a purely from-the-heart initiative. And I say that not to diminish in any way the value of from the heart, but we're spending public tax dollars. We need to know that what we're going to do is going to have an impact. Many people do anti-stigma work and anti-discrimination work, and we called for people to submit their work. And then we asked that critical question: have you evaluated the results of your efforts? They said, well, no. Most people said, no, but we know it's working. We know. Well, you can't just know. You need evidence. So you need to show that it makes a difference. And the evidence tells us that national campaigns that are targeted at everybody don't make a difference. They get diluted out in terms of their impact. That you need to do targeted rather than universal campaigns. So our first 4 targets for the Opening Minds campaign are children, health professionals, the media, and the workplace. Let me tell you a little bit about why we chose this. Children, it's obvious. As I mentioned earlier, discriminatory behaviors and prejudicial attitudes are present by age 10. If you can work with kids, they're much more malleable than adults to change their attitudes and behaviors. There's also a better return on investment. Remember that people born in the 21st century in Canada are anticipated they're going to live to 100. Good luck to them. I'll be checked out well before then. So there's a huge return on investment there. As for health professionals, people took great umbrage, including mental health professionals. They said, what are you talking about? Me, stigma. I'm a mental health I've devoted my life, yada, yada, yada. So the reality is, when you talk to people with mental illness and their families and ask them, where do you experience stigma and discrimination? They tell you the emergency room, my GP's office, the psychiatric inpatient unit, the community nurse. There's all kinds of contexts that involve health professionals. And there's good evidence that health professionals not only embody and incorporate larger cultural attitudes and beliefs as well as behaviors, but they also have a sample bias. And that sample bias is they tend to see mainly people who are not getting well quickly. The people who get well run 100 miles in the opposite direction usually, rather than stay engaged with mental health services, so that the clinicians get a distorted perspective on who can recover and how they recover. The third population is the media, because the media does hold a mirror to society. And so we're doing a lot of work in journalism schools, as well as working with existing media around coverage of mental illness. I recently had to write a letter to the editor. I don't like writing letters to the editor, but Rosie DiMano had written something outrageous about suicide in one of her columns, and we have to be vigilant and stay on top of these things and not allow people to get away with casual, demeaning remarks. The weather is kind of schizophrenic today, right? It's going to rain in the morning, sunny in the afternoon. Those kind of remarks are so hurtful to people who are struggling with schizophrenia and their families. And it's not allowed for almost any other area of healthcare, but it's still permissible within the field of mental health. So what we're doing with all of our interventions in the Opening Minds program is firstly field testing them to show that they really work. So making sure that we have the evidence. They are all contact-based. So although there's an educational component, they always involve people with lived experience of mental illness as very powerful change agents when it comes to stigma. And you've seen lots of news lately about interactions between people with mental illness and the police. And we are all over this issue at the Mental Health Commission, and in fact have been since 2008 with a series of reports and looks at training that exists among police academies all across the country. Now, there is, as you know, an increasing emphasis on the biology of mental illness. People are much more accepting of a biological model of illnesses like schizophrenia and even depression than they were a decade ago. And and there was a big push within mental health to earn that kind of recognition. Why? Well, because it made the illnesses seem more real, because we live in a culture where you need to have an X-ray or a blood test that validates your diagnosis somehow. So people are more accepting that these are brain disorders than they were 10 years ago. However, perceptions of dangerousness have not changed. Social distance has really not changed. So the solution can't simply be in putting forward a model of causation that's actually reductionistic, right? Because this can't be purely biological. To give you as plain an example as I can think of, if you have schizophrenia and you're an identical twin, you're sharing the exact same DNA as your twin. Your twin has a 50% chance of developing schizophrenia. That's higher than a 1% chance the general population has, but it's not 100%. Why isn't it 100%? And perhaps the most interesting area of genetics right now is something called epigenetics. And that is looking at those factors in our environment that turn on and turn off genes, right? Because genes are simply things that code for proteins, and they convey risk. But for most of us, they don't convey destiny. We have genes that put us at risk for all kinds of things, but with the exception of cystic fibrosis or Tay-Sachs disease, most disorders are not purely genetically driven. So there has been some significant change in our literacy level, but not in our social distance level, not in our perception of dangerousness. So there's a number of things that we need to do. And I say we because this is not just about the Mental Health Commission doing this. This is about everyone who's involved in providing health care, trying to figure out what their role is going to be in fighting stigma and discrimination. My colleague Heather Stewart at Queen's University is the holder of the Bell Chair in Stigma Research. It's the first stigma research chair in the world. And she gave her 10 lessons for stigma reduction, which I will summarize for you. First, she said, aim for improvements in the lives of people with mental illness and their families. That's the real goal. Don't lose sight of that goal. Because improved mental health literacy, greater knowledge about mental illness, is inconsequential unless it translates into greater social responsibility, greater social justice, community tolerance, and social inclusion. Number 2, involve people with mental illness and their families in all aspects of program development, evaluation, and communication. And that's exactly what we've done. Accept that education modifies literacy and sometimes attitudes, but very rarely behavior. Use programs that are modest in scope, capable of delivering complex and emotionally charged interventions, because the more emotionally charged, the more powerful the message. Generic, literacy-based targeted at the general public, short-lived and expensive, those are largely ineffective and discouraging. There's no such thing as the general population when it comes to stigma reduction. One size does not fit all. Use the media as allies rather than objects of intervention. The media, you need to know the media, 75% of news is managed news. They don't have enough to fill their papers and television shows. If you go to them with stories, they're usually quite responsive. Sadness, fear, joy, and worry are normal human emotions, right? So, when does sadness become depression? When does fear become paranoia? When does joy become mania? When does worry become anxiety? All right? These are demarcations and differentiations that are challenging, except when you're at the coalface of mental illness. All right? When you are, as I was yesterday, giving ECT all morning to 21 different individuals, many of them outpatients, who are struggling with severe mental illness. There's no question in their minds or in the minds of their families, well, is this just a variation of normal? Is this just what everybody experiences? No, these people were, by every measure, ill and suffering and in need of help. A very senior colleague, Vivian Rakoff, who was chair of the Department of Psychiatry at the University of Toronto in the 1980s, and an extraordinary human being who is also a poet and a playwright and all-around great guy. And about 20 years ago, he said the following, which I think is quite eloquent about the role of psychiatry. He said, physicians were physicians before the invention of penicillin, and psychiatrists were psychiatrists before the discovery of chlorpromazine. The shared identity of those of us working now with those who worked in the past and who will work in the future allows the constant expansion of knowledge without the abandonment of the socially validated human contract between the doctor and the patient. It is the assurance of the patient's right not to be abandoned and of the physician's caring. And that, I would say more broadly, is the social contract that exists between all of you and the people that you serve. Back in the 1800s, there was a physician named Edward Livingston Trudeau. Sounds a little like Jonathan Livingston Seagull. But Edward Livingston Trudeau, who had tuberculosis himself and set up one of the first tuberculosis sanitariums in the United States. And he described the role of the physician, and I would broaden that to the role of all health professionals, as follows. He said it was to cure sometimes, to relieve often, and to comfort always. And it is that latter role that is, to me, so essential in the everyday work that we all do. Finally, let me just say that there's nobody in Canada, when it comes to mental illness, who can honestly stand up and say, not my family. Not my aunts, uncles, cousins, grandparents, siblings, parents, spouse, children, self. So that it's the responsibility of all Canadians who care about a civil society to work toward the end of stigma and discrimination towards people with mental illness, and to be able to say, it's not them, it's us. I'll stop there. Thank you for your attention.